In this episode of Medicine Across a Lifetime, let me begin with a question that may shift how you view your next clinic session. What if the most dangerous vital sign we are not measuring is connection? We measure blood pressure precisely. We monitor glucose trends carefully. But loneliness, depression, and anxiety in older adults often go undetected, even though they strongly influence hospitalization risk, adherence, cognitive decline, and mortality. Recently, I evaluated an older patient whose laboratory results were stable and whose chronic conditions were controlled. On paper, everything looked appropriate. But when I asked about his daily routine, I learned that he spent most days alone. He had lost his spouse. He no longer drove. His social circle had narrowed to almost none. He described himself as fine. As physicians, we know that fine can conceal suffering. Depression in aging rarely presents dramatically. It may appear as insomnia, appetite changes, slowed thinking, irritability, or vague somatic complaints. Anxiety may show up as repeated clinic visits or persistent health worries. These symptoms are often misattributed to normal aging. They are not normal. They are treatable. Nearly 1 in 4 older adults experiences a mental health condition. Suicide rates remain highest among older men. Social isolation significantly increases cardiovascular and stroke risk. These are not peripheral concerns. They are clinical drivers. Cognitive behavioral therapy remains effective in older populations. Mindfulness practices reduce stress physiology and improve emotional regulation. Structured social engagement improves resilience and outcomes. Yet referrals are inconsistent, and behavioral health remains siloed. Medication has value, but pharmacology alone does not restore connection. So let me challenge familiar assumptions. Stability is not simply the absence of acute disease. Stability includes emotional resilience and meaningful human interaction. Practical steps matter. Screen routinely for mood disorders. Ask at least one question about connection in every visit. Identify barriers such as transportation, mobility, or hearing loss. Create streamlined referral pathways. Follow up intentionally. This is not about adding complexity. It is about refining attention. There are ethical and legal dimensions as well. Failure to assess and document mood concerns in vulnerable older adults carries consequences. More importantly, failing to ask leaves suffering invisible. Let me ask you directly. In your next 10 visits with patients over 75, how many will include a conversation about connection? If this resonates, I invite you to engage. Leave a comment about what you are seeing in your practice. Share this episode with colleagues who care for aging populations. Bring this conversation into your department meetings. Isolation is not inevitable. Depression in aging is not a rite of passage. Anxiety is not simply personality. We have the tools. The question is whether we will use them. Thank you for joining me for this episode of Medicine Across a Lifetime. Continue asking better questions. Continue redefining stability. And continue leading medicine across every stage of life.